Today, we're going to talk a little bit together about the association between perioperative hypothermia and surgical complications, something that we all want to avoid. My name is David Shapiro, and I'm going to self-disclose as an anesthesiologist, and I am affiliated with Red Hills Surgical Center. We are located down in Tallahassee, Florida. And as you'll see, I've already implicated myself as the villain of this story, but we'll get to that a little bit later in the presentation. Before we do, no disclosures, as you can see. And we'll be really just talking about everything related to hypothermia and how to avoid it, and really why it's important to maintain that normal thermia, which we're going to be discussing in a moment, in terms of the perioperative experience that you provide your patients with in whatever situation that you are providing care to your patients. So let's get right into it with some numbers, but we're going to spend a long time with these numbers, so you're going to be more familiar with them by the time we get done with this short presentation this afternoon. One of the things that we're going to be talking about again is how to maintain that normothermia for your patients. So to define that a little bit clinically, we want to start talking about temperature, and you can either talk about that centigrade like we do often in medicine, and that's as it's shown between about 36 and 37.5 or 37.5 degrees. And since most of us are listening to this presentation are Americans, we're used to talking about it in Fahrenheit. So it'd be about 96.8 to a little bit over 99 or 99.5 degrees Fahrenheit. And that's what we're aiming to keep our patients in. That's the range. Hypothermia, when we refer to it in this presentation and in other contexts, would be when the core body, and we'll define that in a moment, temperature drops below 36 degrees. So you can see it's on the low side of that range that we described as normothermia up above. The core temperature, if you will, and I'll show you some diagrams reflecting this a little bit more visually, but that's the thermal compartment or thermal part of the body that really is composed of those really super important and highly perfused tissues, which means, of course, that they get a great deal of our blood flow. And that's where the temperature needs to be uniform and actually higher compared to most of the rest of the body. The ambient temperature is just a fancy way of saying temperature of surroundings. So if you want to impress people when you go outside, you can refer to the ambient temperature instead of the weather. And then the ideal thermic state is, again, just referring back up to normal thermia, where we want to keep our patients. And that is, again, around the midpoint in that range. So about 37 degrees, or again, in Fahrenheit, about 98.6. Either way you look at it, that's where we want to be aiming towards with our patients as we take them through their perioperative experience. As I said, we're going to be talking a lot about how to maintain normothermia. So just want to make sure that we talk about that in a little more detail, since we'll be mentioning it so frequently in this presentation. Basically, temperature is really important for so many bodily functions at the cellular level, but also at the temperature control level, in terms of the physiology that lays behind that normal temperature range. So we really want to keep it within about 0.2 of a degree centigrade. And that is on either side of that 37 degrees. That's your inter-threshold range, as you can see on the slide. And that's where active measures of heating or cooling are not triggered, because you're still within essentially those normal limits, or around 37 degrees centigrade. So then there's also a set point temperature which exists, and that's where the body maintains steady states in the core body temperature. And that's the range of there is about 1/2 to 1 degree centigrade. And that's based on your circadian rhythm. So that's why you tend to cool off during sleep and heat up, if you will, as you resume physical activity starting in the morning when you first get out of bed. So that's the normal, and that is how most of us control our temperature on a daily basis. Again, not while we're having surgery, and that's why we're going to talk more and explore that together. So how does this temperature regulation work? Well, there's a lot of different ways that we regulate peripheral as well as central nervous systems throughout our body to regulate that temperature. And I won't go into detail even as far as it's depicted on that slide, but you basically have nerve fibers that on the external core of your body, at your skin, we sense the environmental temperature, again, that ambient temperature in whatever environment you're in. And then those sensors relay temperature signals from the skin right through your body to the spinal cord and the deep abdominal or thoracic tissues. And that is basically controlled by the hypothalamus, the area in your brain that really is in charge of doing all this work that we've talked about in terms of regulating your temperature and keeping you within that normal range during normal activities. So again, most of us during most of the time tightly control that core temperature through all these means. But then, as you know, if you get into some place that is a little bit too hot, you begin to sweat. If you get to some place that's a little bit too cold, you begin to do things like shiver. So just normal things that we're used to in terms of how we react to the normal temperature changes that we encounter throughout the seasons of the year, whether you're inside or much more pronounced, of course, outside. So that autonomic regulation, including the peripheral vasoconstriction or dilation, is mostly dependent on that core temperature and that temperature of your central organs within your body. So the human body loses heat basically through 4 ways, and we're going to depict that, but just to introduce them to you, the 4 of those are radiation. That's the transfer through an infrared mechanism of heat. The other is convection, which is the movement of heat based on airflow. So that can be even outside with cold air blowing over the body, or conversely warm air. Conduction would be heat transfer through physical contact with an object, either hot or cold if you touch something hot, or in this case, we'll be talking about laying in a cold operating room and being in contact with cold operating room tables. And then the 4th of those is evaporation, and that refers essentially to the loss of heat through sweat from skin or fluid loss from exposure to the open atmosphere in the normal circumstance. But of all those 4, the most significant heat loss, which again is what we're worried about in the operating room setting, or about 60% of that does occur by radiation. So that's one of the ones that we're going to be really interested in trying to modify through our mechanisms by which we want to prevent hypothermia in our patients. So here's a picture to go back over what I said. Again, that radiation, as you can see from those squiggly arrows coming off the person laying on that table, is heat transfer to the cold environment. Convection would be the heat transfer to the air currents, or what the prevailing air is around the individual. Conduction would be that contact, and you can see that's pictured by those downward arrows on the diagram. And then evaporation is heat transfer from moisture on the body surface, again being evaporated or changing from a liquid to a gaseous state. So again, we want to concentrate, if you will, on that core versus the peripheral temperature regulation, because that's where all of the action takes place, if you will. Because again, that core is deep inside your bodies, and your periphery or your skin is much closer to that external temperature, whatever that temperature may be. So those non-core tissues may fall significantly below those core temperatures, and that may occur well before the core temperature might ever fall or decrease below that normal thermic range that we're aiming to keep it at. So in a resting patient, a large portion of their heat is generated by your organs, those internal organs of the thermal core. And under normal circumstances, again, when you're not in an operating room setting, the body can control the rate of heat loss from the core through all of the mechanisms that we have described so far. Unfortunately, though, we are talking about the perioperative experience to which we expose our patients. So this hypothermia is unintentional, of course, but as we all know, we're putting our patients in a cold environment, and it does occur in over 90% of, so almost all of the patients, unless we impose some regulatory mechanisms to try to help keep those patients normothermic. So as you can see, this is not an unusual occurrence unless you are able to prevent that hypothermia from occurring. So it's something that we all need to be aware of as we expose our patients to the environments in which we provide them surgical or procedural care. So again, what are the causes of unintended hypothermia in our surgical patients? Let's explore that in a little more detail in this section of the presentation. There are, of course, multiple factors, and we're going to concentrate on the main ones. The biggest one, of course, is the one we're probably all aware of. It's cold where we work. Operating room temperature contributes to intraoperative hypothermia, primarily through that radiant heat loss that I've described to you earlier. Although most operating rooms have thermostats, we can control the temperature. As you know, there's often disagreements about what the optimal temperature is based on the comfort of the people that are working in it. And of course, you know, many of the folks, especially those of our surgical partners, are wrapped up in gowns and possibly other layers of clothing, including their scrub suits. But sometimes some of those, you know, real heavy protective devices that they have on if you're using radiologic equipment. But they're also standing under hot lights and tend to get a lot warmer than most of us, and certainly a lot warmer than most of our patients who, again, are exposed to these cold temperatures and again, are on those cold operating room tables. So the additional heat loss on top of that occurs through conduction as we put our patients on those cold operating room tables and by those mechanisms of convection through the laminar airflow in the operating room. So those additional causes of hypothermia, I think we've mentioned most of them, and certainly most of you, if you work in an operating room or even set foot in one, either as a practitioner and or as a patient, those cold operating room temperatures, we then give them cold prep solutions, which aid in heat loss through evaporation, especially if we're prepping a large area of the body. And then we go and give them cold fluids or infuse cold fluids and blood through our intravenous lines that we've placed or will place in the patient. For a lot of our procedures that are not done through a scope, we then expose the body cavities, further exposing the patients to this cold environment. And then, of course, all of this is compounded when we do more lengthy procedures, even though, as I'll show you in a short procedure, a lot of these deleterious effects tend to occur really early in our cases. So what is the patient's response to this temperature that we have provided them an exposure to? Well, concurrently, exposure to the cold procedural environment, and then vasodilation induced by either general or regional anesthesia further compounds all the cold things that we have mentioned that we are doing to our patients. So again, under normal circumstances, when a patient is not being a patient, not in the cold operating room, we would initiate, and our patients would initiate, mechanisms to preserve or create their own heat in the face of a cold environment. For instance, if they're going out in the snow during the winter. However, as I've described, I'm an anesthesiologist, and we are in some regards a villain in this regard, because anesthesia further disrupts the homeostatic mechanisms that would allow us to keep ourselves warm in a cold atmosphere. So how does that do that? We're going to spend a little bit of time talking about that. We're not going to go into all the extreme detail of the physiology, but just basically to remember that hypothermia is related to what anesthesia causes, which is that anesthesia-mediated decrease in SVR, or systemic vascular resistance. So that general and regional anesthesia induces the peripheral vasodilation. So out at the skin level, the body heat is diverted from its core to the periphery, and therefore that exacerbates the environmentally caused hyperthermia, or the hypothermia caused by the cold operating room environment. So not surprisingly, given that, anesthetized surgical patients can't regulate their temperature through the normal behavioral changes. It's things like shivering that we talked about before, but they have to rely on the body's, internal thermoregulatory system and clinician intervention. That's where we come in to regulate their temperature. In addition to that, I'll just mention quickly, some of the drugs that we give further dampen the behavioral response to cold by preventing that shivering. Something like muscle relaxants would further disallow a patient to do what they would normally do in response to a cold atmosphere. So we've really stacked the cards against the patient in the operating room by not only placing them in this cold environment, but then further, for most of our patients, giving them anesthetic medications, which of course they require, but which further exacerbate the system. So here's a little graph that just shows you a visual representation of what I've been mentioning would occur in that normal, 0.2 of a degree, so real narrow intra-threshold range. So on the cold side, you've got that vasoconstriction and shivering that would occur. And on the warm side, you would have that vasodilation to let off heat, and sweating would occur in a normal situation. However, not in an operating room. Thermal regulation under anesthesia changes all these dynamics. As you can see from this slide, as opposed to the one previously, that inter-threshold range becomes greatly expanded to about 4 degrees from that 0.2 of a degree. So that vasoconstriction doesn't kick in until the body is much, much colder. And of course, on the warm side, we're not going to worry about too much. But again, those mechanisms would not kick in until much, much later, or in a much warmer situation. But we're really concerned about the left side, if you will, of this picture, because of that anesthetic impaired reduce to the cold temperature that we have placed the patient in. So what are the things that we're doing as anesthesia practitioners? Well, we're causing vasodilation, or an opening of those arterial shunts, again in the periphery, which allows the warm blood from the core to flow freely and mix with the colder periphery. So as you can see, that starts to get the core temperature, the one that we're the most worried about, a little bit colder than it normally would be. So as that blood circulates, it cools, and then it returns back to the heart and to those core organs, where it causes a temperature drop, as you can see on the right side of the diagram. And that is what's known, of course, we have to have a fancy term for it, as heat redistribution, or RTD, otherwise known as a redistribution temperature drop. So that is really what we're doing to the patient to disallow their compensatory mechanisms to account for the fact that we have placed them in this cold environment. Further, there's the time element. That core temperature can drop about 1.5 degrees or 1.6 degrees in the first hour of a general anesthetic. So the primary time that occurs is in that initial stages of anesthesia. About 80% or 81% of this temperature decrease is due to what I've been describing, which is that core to peripheral heat redistribution. So it happens very profoundly, and it happens very, very fast. Because it's so difficult to treat this redistribution, what we want to do is start thinking about how to prevent it. And what we're going to be talking mostly about is pre-warming. The reason is that pre-warming increases the temperature of the periphery. So again, the extremities, the skin, which limits the amount of that heat that is lost from the core during that redistribution that I showed you a pictorial description of in a prior slide. So to maintain normothermia, again, the object of really what I'm hoping to pitch to you today is the knowledge that the induction of anesthesia is the most significant contributor to that unintended perioperative hypothermia in our surgical patients when they are anesthetized. So what we want to do is reduce the impact of that redistribution temperature drop through the pre-warming as an effective way to help maintain that patient within that fairly narrow normothermic range that I described to you earlier. Just want to mention that a regional anesthetic, although that's a great way to treat patients during their surgical procedures, does not obviate the need to do this pre-warming. Regional anesthesia is a great technique, should never be discounted, but it does unfortunately allow a lot of those mechanisms that would normally keep a patient warm to kick in. So the patient does get cold like they would during an intravenous or an inhalational anesthetic during a regional anesthetic. So again, central and peripheral thermoregulatory functions are impaired, again, with regional as well as other kinds of anesthetic techniques. Nerve blocks also prevent normal responses and further disrupt the nerve conduction that would signal to the brain that, hey, we're getting cold in here. So skin temperatures in blocks areas are misjudged by thermoreceptors, even if a patient is awake or semi-conscious. So patients also often might even feel warmer due to really misinterpreted or incorrect perceptions of thermoreceptors in the area where you've blocked. For instance, in the case where an anesthesia practitioner has done a block for a peripheral procedure, for instance, on an arm or a leg. So that hypothermia is frequently undetected in patients under regional further because core temperatures are maybe not monitored as frequently. And also, again, patients, if they are at all awake, they would not typically express feelings of thermal discomfort or being cold. So why is this so important? Why am I spending so much time describing to you the physiology behind how this hypothermia occurs? Yes, it is very uncomfortable, but as we mentioned, most of the patients, unless they're awake or semi-conscious during the procedure, wouldn't perceive it. So why is it that it's so important to keep them within that normal thermic range? Well, there are a lot of reasons. I'm not going to go into too much detail, but I did want to go over the basics. Call these the 7 deadly sins, if you will. That those negative outcomes of that inadvertent perioperative hypothermia are truly severe, and they're really wide-ranging. Again, we've defined that as a core temperature of less than 36 degrees, so on the short side of where we want to be for normothermia. But we tend to overlook the fact that it affects so many parameters and really affects things that we're very concerned about on the patient's behalf during their perioperative course. So we're going to be looking at wound infection, coagulopathies or how their blood clots, prolongation of drug effects, sometimes cardiac disturbances can even result in mortality. And then again, the things that patients may or may not remember, but certainly we do want to avoid, which is that delayed emergence from anesthesia, and also that always something we want to avoid, that shivering and really uncomfortable feeling that a hypothermic patient might get should they continue to be hypothermic during their perioperative period after they've come out of the operating room and they are in the recovery area of your facility. So let's take a little bit closer look at that and just suggest some of the ways in which that occurs. As far as the drug metabolism, as I mentioned, the hypothermia that we induce in our patients does prolong the effect of drugs. It basically impairs some of those enzymes that are very susceptible to temperature variations that would normally metabolize and clear the anesthetic drugs, so thereby increasing their duration of action within our patients. It also, again, affects the potency and may even cause these drugs to become more potent for a hypothermic patient. There's been a lot of studies done, but again, some of the common things that we use, so Versed, narcotics, morphine, propofol, neuromuscular blocking agents like vecuronium, rocuronium, all are prolonged due to the pharmacokinetic effects on that hypothermia. So we know that we want to make sure that the patient, especially if we're discharging them home, since most of our patients are done on an outpatient basis, we want to make sure that the drugs that we want to be gone, most of these anesthetic agents, we want to make sure that the body's had a chance to metabolize them. And we know that to be very much impaired if the patient is hypothermic. So not surprisingly, that increases the length of hospital stay and PACU or recovery room time. And there's many studies that have been done that really documents the amount of time that is spent extra in recovery with these patients, not only feeling uncomfortable, but also are impacted by this prolongation of the pharmacologic effect of the medications that we have given them. So again, lots of studies to support this. As far as blood loss, there have been a lot of studies also that really attempted to quantify or determine whether hypothermia leads to increased blood loss and transfusions. They've given a little bit inconsistent results, but I think the potential causes for the increased blood loss include hypothermia-induced platelet dysfunction and dysfunction, again, back to that enzymatic aspect of coagulation cascade, where those enzymes are very, very sensitive to temperature, especially decreases that would disallow the normal workings of the enzymes to provide for that coagulation that we certainly want the patient to have, to make sure that they're not bleeding more than they otherwise would have after a surgical case. Wound infections or any kind of surgical site infections, again, have unfortunately been associated with even mild hypothermia, and due again to this vasoconstriction that we've said happens at the periphery and the change in oxygen tension. So at really cold temperatures, or 34.5 degrees centigrade, thermoregulation again leads to that peripheral vasoconstriction, and this causes the oxygen delivery to subcu tissue to decrease, which naturally impairs the strength of the collagen, and this all leads again to what we don't want, which is either prolonged healing or, since from the decrease in perfusion, a propensity towards increased frequency of wound infection. So really, really want to be careful, because clearly one of the things that we want to avoid in our patients are those SSI or infections at the surgical site. Talked a little bit about shivering and thermal discomfort. I can tell you as an anesthesia practitioner, it is one of the things that the patient will remember about their perioperative experience. If they wake up and they're cold, they are going to be shivering and they are going to possibly be in pain, but they're really going to be uncomfortable with that shivering and also be affected by the increased oxygen consumption and the vasoconstriction that goes along with that hypothermia that really I'm pitching to you we want to avoid. So that's 4 times dependent on the core temperature over the skin temperature. So again, as soon as you let that core temperature drop, you're really going to have a problem trying to alleviate that shivering that naturally occurs as the body tries to generate its own heat and overcome the hypothermia to get to their normal thermic state. So again, all these patients are going to be vasoconstricted. And there's been a lot of studies that show how vasoconstricted patients are, looking at temperature and also blood flow throughout the periphery. So postoperatively, again, really want to be aware that hypothermic patients have experienced that persistent vasoconstriction for quite a long time, actually up to about 6 hours, which is quite a while after we want them to be feeling warm and possibly ready for discharge. And that's, again, going to increase that rate of shivering, which we know patients, and through no fault of their own, really, really want to try to avoid. So again, that shivering and thermal discomfort is something that a patient will remember, and it's something that is so easy to prevent through the warming that I'm going to show you about in a moment. So again, just to summarize, that unintended perioperative hypothermia occurs in so many of our patients, maybe even more than the 90% that's often cited as the frequency in a lot of the studies. But it is definitely frequent, and it is definitely preventable. Again, 81% or majority of that temperature decrease occurs really early. So within the first hour, especially if they're given an anesthetic, due to that core to periphery redistribution of the heat that I explained earlier. So because, again, it's so difficult to treat that redistribution of the heat, we want to try to prevent it. And that's what I want to show to you in terms of things that we can do to really minimize, if not completely prevent, all of those negative outcomes from occurring during the patient's perioperative period. So let's take a look at some of the things that are involved with pre-warming, really, again, to prevent that perioperative hypothermia for our patients. So I keep mentioning pre-warming. Let's try to define it. It's really pretty simple. It's the application of heat prior to anesthesia. Again, we showed why that's important in terms of the timing, but if for the purpose of increasing that total body temperature. So again, that total body temperature is the average combined temperature of both the periphery and the core that we talked about. But that pre-warming allows the patient to bank heat, if you will, which significantly increases the peripheral heat content. So it's really really giving them a head start, knowing that we're going to place them in this cold environment and do all those things to them like the we have described, such as putting them in contact with a cold operating room table, giving them cold intravenous fluids, and all the medications that I mentioned earlier. So again, one of the things that I've heard people say a lot after giving some of these lectures is that we don't really have to worry about our patients. Maybe I'm in an ASC, maybe I'm just doing short procedures in an operating room in a hospital setting. But regardless, there's a misperception that a short procedure really doesn't incur these hypothermic or potential hypothermic situations. Unfortunately, as we've explained, that core hypothermia begins developing almost immediately after the onset of anesthesia due to those effects of redistribution, which we can't really quickly reverse if we hadn't started this warming preoperatively. So we really don't want to even wait until they've started their surgical procedure. They can be hypothermic again after as little as 15 minutes of that anesthesia induction. So patients who are undergoing these shorter procedures who are properly pre-warmed and receive intraoperative warming can remain normothermic throughout that perioperative period. And that's really what we're trying to do, even again, if you're working in an ambulatory surgery environment and having a shorter perioperative period. Really want to emphasize the point that this can and certainly does occur in probably almost all, if not about 90% of our patients. So what are the ways that you can warm a patient? Well, let's just talk about them, and then we'll talk a little bit about how they compare to each other. Again, there's many different ways you can divide them up. It's easy to think about them that way in terms of both passive versus active warming. In passive warming, it's pretty simple. A layer of some kind of insulating material is placed directly on the patient. So that can be anything from those cotton blankets to warm cotton blankets, maybe giving them some of those little socks or booties, putting head covers on them. Certainly in the operating room, cover them with surgical drapes, are all elements of passive warming. Active warming is the application of heat. So that can be done in a variety of ways also. There's conductive fabric devices. We'll talk about those briefly in a minute. Circulating water devices. Fluid warmers that we talked about might alleviate some of those, the temperature of the intravenous fluids. And then there's forced air warming, which I'll be suggesting to you is one of the most effective ways that we can prevent this hypothermia from occurring. So pretty much if you've worked in an OR in the last couple of decades, you're familiar with cotton blankets. We know them, we love them, but just remember these are great, but they are passive warming devices. They're passive insulators. They do not provide that active warming that is so important. So even if you are warming these blankets, that heat is quickly lost to their surroundings. In fact, if you've ever put one on yourself, either in the operating room or somewhere in your facility, you know that that nice warming effect only lasts for a minute, possibly a minute or two. So that patient heat loss is virtually identical with warmed and unwarmed cotton blankets. Even though we are doing something that we know feels good in an awake patient, it really isn't that effective in keeping the patient warm for the long haul or during their period that they're with us. Then there's that convective versus conductive warming. Convective is the transmission from a forced air warming blanket to the patient by circulating the warm air, whereas conductive would be the transfer of heat where there's direct surface contact, and that would be most predominantly at the body's natural pressure points. So that conductive warming, there are various warming methods that fit into that category, such as circulating water mattresses, where you use warm water to warm up the patient. There's warm water garments that you can apply. There's resistive elective covers, sort of like an electric blanket. And then there's smaller devices, somewhat like heating pads. But those conductive modalities are designed to be in direct contact with the skin to improve heat transfer from the device to the patient. So the heat is provided only where there's that surface-to-surface contact. For the circulating water mattresses, again, basically you're having heat moving from a warm mattress to the colder body with that contact at the point where the surface of the warm mattress contacts the patient. So that the effectiveness of that heat transfer is limited to the relatively small surface area in contact with the mattress. And those are surface areas, unfortunately, that are typically poorly perfused. So they're really not able to do the job that we want as you think about that heat redistribution that occurs from the periphery to the core. So the combination of heat and pressure can also increase, and this is an unfortunate side effect of trying to use some of these devices, the potential for thermal injury. In other words, that heat stays in contact with the body for too long at these pressure points, and you can actually have a patient sustain first, if not second degree burns, which is something we certainly don't want to add to the injury of whatever procedure we're performing for that patient. There have been a lot of studies focusing on the effectiveness of resistive electric warming modalities versus forced air warming. But basically, to summarize, what they've really found is, again, that forced air warming is far, far superior, both in the rapidity and the effectiveness and the duration of the warming that occurs in patients that were given this type of technique to keep them in that normal thermic range. So what does this look like? Here's a little diagram. This forced air warming or convective warming is really effective due to modulating or preventing that heat loss due to convection and radiation. So the heat transfer is due to that gentle dispersion of the warm air across the patient's skin. And again, those forced air blankets transfer more heat while operating at a relatively low temperature. And that's one of the reasons why they're almost impossible to give you that thermal injury that unfortunately so often happens with the warmed or hot water mattresses that have been used in the past. So let's take a look at a little bit of a comparison between a control and a forced air warming. As you can see, that top line, or the colored one, you will see that the forced air warming provides a really effective therapy, even when only 50% of the body is covered by the device. So even if you're not covering the entire body with a forced air warming device, maybe you're working on the lower extremity, so you've just covered the upper thorax and torso, that still has a great effect to help you keep that patient normothermic. And as you can see, that compared to the control, it really blunts that decrease or that curve in terms of especially keeping that patient close to normothermic for the duration of the surgery, even if it persists past the hour that many of our surgeries are accomplished within. So that forced air warming effectiveness, when you compare it to some of the other techniques, for instance, those heating or space blankets, a control, humidifier, humidistat, as you can see, that top blue, if you will, line is the forced air warming. And as you can see, again, has the same effect to minimize or even prevent that decrease in temperature that still occurs even with some of those other techniques. So it's really important to keep this in mind when you're considering which kind of warming device you would like to use for your patients at your organization. Again, this shows the same thing. It's just displayed in a little bit different kind of graph, but it shows you the relative effectiveness of that forced air warming all the way on the left side of the graph in terms of being able over a great deal of time to keep the patient's body within a warm or normothermic range, much, much better than some of the other things that we've talked about, including the application of blankets, again, that circulating water mattress, or even the heated cotton blanket that we mentioned before. So really no need to take my word for it, although I hope some of this data has been convincing you. And I'm not going to certainly read all of these, but some very, very well-respected external agencies and organizations have also come out with recommendations that support both the reasons that I'm sharing with you and also the mechanisms for pre-warming that I've suggested to you. So ASPAN, or American Society of Perianesthesia Nurses, CDC, AORN, all have come out with supportive documentation that this really does work for all of, and is so important for all of the reasons that we mentioned towards the beginning of this presentation. So forced air warming, want to summarize some of the clinical evidence, because certainly there have been a lot of studies that have been done. It does not, and this was a problem in the past with a lot of allegations or conjecture, if you will, it does not increase the bacterial contamination of operating rooms. This has been shown time and time again. Unfortunately, during the early stages of the introduction of some of these forced air warming devices, that was something that was rumored, but absolutely never proven, and has been disproven recently in many, many studies, showing that there is absolutely no bacterial contamination of the ambient operating room environment. And I have some citations up for you if you care to go back and review some of those studies that have been done and documented at your own leisure. So let's take a look really quickly at some of the strategies and evidence-based practices for the prevention of that hypothermia. Let's just take a look at developing some normothermia guidelines for your organization. It's really important to consider how important this is, not only for adults, but for children. So I want to mention and point out that because of the increased body surface area to mass ratio over adults, that children are even more increased risk of hypothermia. So that pre-warming is really, really strongly recommended for children, including the warming that can be done through warming their fluids. So all of the things that I mentioned for adults in the past have been really proven to also very, very profoundly affect children and their ability for us to keep them warm during their surgical procedures. For adults, of course, we've talked about mostly the patient warming efforts are made to minimize those effects that we've talked about, especially after anesthesia induction, including redistribution, but also to minimize that cutaneous heat loss and restore and maintain, really important, that normothermia that we like those patients to maintain throughout their perioperative course. So all the way from pre-op to intra-op to post-op, we really want to keep those patients normothermic. So your strategy, of course, is going to depend on whether the hypothermia is being prevented or treated. But I really want to strongly suggest, for the reasons that we've mentioned, that you really try to institute these parameters earlier rather than later, especially given the ability of them to prevent rather than try to recover or treat the onset of hypothermia. So some of the guidelines that have been developed are really suggest that all patients, again, regardless of the type of anesthetic that they are going to be experiencing, should be pre-warmed with that forced air warming at a high temperature setting for at least 10 minutes. That's before they go into the operating room. And during that time, you want to start to measure their continuous temperature, especially as you're taking the patients into a much colder environment. I think we've gone over the reasons why, but again, you want to make sure that you have compensated for that patient's disability to be able to combat the operating room environment that we have placed them in, and to keep themselves in that normal thermic range around, again, 37 degrees centigrade. So things you want to do: rapid and aggressive warming of patients, pre-warming requiring the transfer of heat into the body by those active warming devices to minimize that heat loss from the skin, by forced air warming. So all of the things that you're doing can really, really help a patient maintain that normothermia, but nothing is more effective when you then adding into that compendium of techniques that you have available, that forced air warming and some of the devices that are available out in the marketplace. So intra-op, you want to limit the end of the time between pre-warming and induction to less than 10 minutes. You also want to, again, consider the use of a fluid warmer to add into your armamentarium of things that you can do for the patient. And especially if the patient's anticipated length of anesthesia is going to be greater than a half an hour, they should receive that intraoperative forced air warming during the entire time they're with you in the operating room. And again, we've talked about the reasons why and the reasons why it's so important to do this, especially given the timing of the deleterious effects of the environment and also the anesthetic medications that we are often giving our patients. Postoperatively, again, you want to continue what you've been doing preoperatively and intraoperatively into the post-op period. So surgical patients should, of course, be warmed until they're thermally comfortable and have a core body temperature within normal limits. So you want to continue to monitor that throughout the post-operative period. But again, you want to really make sure those patients remain normothermic. And as they're waking up, you want to prevent that shivering. Then I promise you, patients really dread if they've experienced it before. And if not, they unfortunately remember that unpleasant sensation of being so cold and shivering so frequently during their recovery period, when of course they are coming out of their anesthesia and may also have somewhat of a painful episode based on their surgical or procedural intervention. So, and just another reason to really consider these devices as something that you want to use throughout their perioperative course. So to summarize here, we're close to the end of our time together, but we want to make sure that you start this in the pre-op for patients, especially using that forced air warming device, continue that into their intraoperative period, and continue it through their post-operative course so that they stay comfortable and again, keep that important core temperature within the normal range. And please remember as you're doing this to continuously monitor their patients. It is really an important part of the way that you keep track of how your patients are doing during their time with you in your perioperative environment. So kind of winding up here, you really want to treat normothermia as a always event, or conversely hypothermia as a negative event. But a great thing to do is to start looking at your current performance. I'd even suggest maybe doing a quality assurance performance improvement study. You want to standardize your temperature monitoring method so that you can keep track of the effects of the interventions that you provided. You want to do evaluations, especially if you think your patients are high risk. We mentioned pediatric patients, but certainly others are at higher risk than others. You want to really watch those temperatures in the operating room and the perioperative environment. Stick to those clinical practice guidelines. Again, as I mentioned, so many organizations have put those forth, and I'm sure that they are easy to access either on the web or through some of the material that you have available at your organization. Again, evaluate the appropriate use of all those pre-warming devices to make sure that whatever you're using is used according to the manufacturer's instructions, because anything that you do to a patient always has the possibility for misadventure, and you want to make sure that you're very careful and do everything to protect the patient and make sure the patient stays safe while they're with you. So educate everyone, your staff, your physicians, anyone that comes in contact with your patients, and always include the possibility of hypothermia as an element of your timeout that you conduct prior to the initiation of your procedure while you're in the operating room. So I'm going to wind up here. We have some time for questions and answers. And before we do that, I want to thank you for listening to this presentation. Hopefully, I've been able to convince you to at least strongly consider both the avoidance of hypothermia and the maintenance of that important normothermia, and especially the use of those forced air warming devices. So I thank you again for taking the time to listen today and look forward to answering some of your questions. Greetings, everybody, and thanks for joining us this afternoon for all of these presentations. I hope the presentation regarding post-op hypothermia is helpful to you, and that you found it to be applicable to at least some of the things that you're doing in your real lives at work in whatever organization you work in. A couple of questions have come in. I want to address those, but I'd certainly encourage anyone who has any lingering questions, whether it's pertinent or exactly related to something I covered or something a little different, please feel free to type them into the chat box and I will read them back. before I answer them, or at least try to answer them. Just one other disclaimer, which is that I am broadcasting to you from a surgery center that I am affiliated with. So if there's any background noises, hopefully they won't be too disruptive, but I'm not able to shut off the overhead paging system just because we're doing this webinar together. So I apologize in advance if that occurs. So a couple of really great questions I want to kick off with. First one is, and I'll just kind of paraphrase them, but what is the effect of the limb temperature distal to when a tourniquet is used? So that is a great question because especially if you work in an orthopedic surgical environment, you'll know that a lot of the procedures that we offer patients utilize a tourniquet for all or part of the procedure. So if you think back to the way that I described the mechanisms for patients getting hypothermic, you'll realize that when the tourniquet is up, that temperature redistribution drop, or that RTD that I mentioned, just a really complicated acronym for that, it will really not involve that limb that is shut off, if you will, from that core circulation by the tourniquet. But nevertheless, I don't want to dismiss any case that involves a tourniquet as not being susceptible at all to the development of this hypothermia that we're trying to avoid. So I would say, in answer specifically to that question, yes, that aspect or that part of the anatomy will not be involved necessarily in the temperature drop, because that cold blood will not be recirculating back into the core as it would if the tourniquet was not up. But nevertheless, all of the other mechanisms are in place, and since the tourniquet will only be cutting off a small part or small percentage of the circulation, I still think that research will show us that even with the tourniquet up, there is still a very, very high potential for those cases, or those patients undergoing those cases, to have the potential for hypothermic episodes. So great question. And I'm going to move on to the second one. I see some others coming in, and I thank you. This is asking about whether postoperative hypothermia combined with medications could cause post-op delirium. That's a great question. I didn't include the discussion of post-op delirium in my presentation, mainly because the most recent studies that I've seen, one back in October actually that I have in mind from the Journal of Anesthesia Nursing, really explored this, as well as there's been some other studies. As you can imagine, post-op delirium is based on a lot of other things, but what they're saying now, and I'm just going to quote, I jotted down, preliminary understanding of this relationship is based on the response to surgical stress. And although there are mixed findings from the research that was done in this article I mentioned, and also others regarding the relationship of hypothermia to development of post-op delirium, there is little or no supporting causal evidence in the literature. However, that doesn't mean that you won't see it. It just means that we are not really quite clear as to the exact mechanism that post-op delirium is created by. So I think that it can be easily stated that anyone that is undergoing a procedure, especially if those anesthetic medications are given, that if they are hypothermic, just as I described, their chances for exhibiting symptoms of post-op delirium are even higher and last longer. And that's a really kind of frightening part, or the take-home message, because it ties back to something I mentioned earlier in the presentation about the prolonged effect of especially anesthetic medications that is caused by that hypothermia. So if they are going to experience delirium, and they might well be at an increased risk, that might potentially last even longer into the postoperative period. So it's a great question and something to consider. Question just came in, so I'm going to read it, take a quick look at it for the first time with you. And that's, how are you monitoring pre-op and post-op core temperatures in patients? It says, with no esophageal temperature probe in place at these times. And yes, that is a terrific question. basically, you have to decide what is best for your patient population. And that's going to really depend on a lot of things, including the length of the surgical procedure, but also the kind of anesthesia that is given, and most importantly, the site of the surgical field, because you certainly don't want to be interfering in any of the surgical field that you want to keep sterile, again, to prevent infection, which is really one of the main reasons that we're spending the day together. So there are all kinds of temperature probes that you can purchase, but I'll just name a couple. Axillary is relatively non-invasive and actually fairly accurate, surprisingly, for one aspect of skin. But also bladder, not probably good for most outpatient procedures, but might be an alternative during longer, more invasive procedures. So bladder temperature. Esophageal, as was mentioned, but of course that contemplates having a temperature probe, and usually would only be appropriate if the patient had some kind of airway protection, either an LMA or an endotracheal tube. Certainly oral is fine. Rectal, for some cases, is absolutely appropriate and approximates very closely core temperature. And then the temporal artery and also tympanic. So in the ear is also a great place, especially if you're having upper lower extremity surgery, to measure and get fairly accurate readings for temperature probe. Also, skin temperature can be used, but just recall that that is probably the least accurate. And so you really want to be careful about how you interpret it, especially if you're using one of those kind of stick-on temperature probes that many of us use, especially for those shorter cases where we don't want to involve more invasive types of temperature monitoring. So anything will do, but please realize that they vary with not only where you're able to do that, but also in terms of how closely they approximate the core temperature. So be very careful, and I will also suggest that you be consistent. So whatever you start monitoring in the preoperative area, continue into the intra and further into the post-op or recovery area, so that you are not changing back from one type of modality to another, and you get consistent readings throughout the patient's perioperative experience in your organization. Next question is, if for abdominal surgery, which is more effective, forced air on the top, maybe this means, or lower extremities? So I'm not exactly sure what that question is. But basically, I think the answer I want to tend to is you want to cover as much of the surface area as possible. And many of the companies that provide forced air heating units have all kinds of different areas that they can cover based on what you buy and what you hook up to the unit. So there's things for upper extremity, there are things for lower extremity, there are total body, and you just need to adjust those. Certainly if you were doing the abdominal surgery, as is mentioned in the question that was posted on the chat box, you couldn't really use a warming blanket on top of the abdominal area. As I said, you want to keep that absolutely sterile, especially if it's an open case. So you would use some of the either upper extremity combined with maybe a lower extremity blanket to keep the patient, again, as warm as possible, especially if you're doing abdominal surgery that either A, lasts long, or B, involves an open procedure where that abdominal cavity is exposed to the air and sometimes cold irrigation fluid. Great question, also just got asked, and it's something that I didn't emphasize enough. This is a really great point. The question is, I'll read it word for word, is there an increased risk of infection using forced air perioperatively? I will tell you that I have a feeling that the author of that question is recalling some literature that was really refuted very, very strenuously in subsequent publications that did intimate in the past that there was a risk of contaminating the air from the air that was coming out of the forced air units. That has been absolutely refuted. There is no current evidence that there is an increased risk of infection from these forced air units. So I would encourage you to go look that up for yourself. Certainly don't take my word. Great questions. I'm going to have to wind up because we're at the end of this session. So I want to thank you again for listening to the presentation and also for your great questions that I hope I had an opportunity to address to your satisfaction. So thank you again.